So, good evening, all. Welcome you all
Good
to
evening,
the
sir.
July session of Spice Road Kerala Classroom, which is being hosted by MGA Muthoot Hospital for the month of July. So, we'll be having a neurology case presentation today, which will be done by Dr. Srilakshmi, who is a DNP Family Medicine resident at MGA Muthoot Hospital, Pathanamthitta. And the session will be moderated by Dr. Jibuju, who is a consultant neurologist at MGA Muthoot Hospital, Pathanamthitta. Over to the presenter and moderator.
Okay. Thank you. Thank you everyone for giving me this opportunity. Let's start. Sir, am I audible? Jibu sir. Sir, mute.
Okay. Now I am audible, right?
Okay, sir. Shall we begin?
Yes.
Okay. Patient is a female patient of 48 years old, and she is coming from Rani. And informant is patient itself. And date of examination is on the same day of date of admission. Chief complaints are sudden onset of weakness of left upper limb and left lower limb, deviation of angle of mouth to right side, slurring of speech since morning of 15th July 2024. History of presenting complaints. Patient recently diagnosed with a systemic hypertension and type 2 DM and was on lifestyle modification, otherwise was apparently normal. Patient woke up normally on 16th July and prepared the breakfast. After having her breakfast, she suddenly developed slurring of speech and deviation of angle of mouth noticed by her husband. Patient also had difficulty in walking, climbing stairs, lifting the hand overhead, gripping her slippers in left foot since then. No difficulty in holding a glass of water, taking food to mouth. No history of involuntary defecation and micturition. No history of trauma or fever. No history of headache, vomiting. No history of loss of consciousness and seizures. No history of decreased sensation. No history of decreased smell, blurring of vision, double vision. No history of decreased sensation over the face, decreased hearing. No history of difficulty in swallowing or nasal regurgitation. No history of chest pain, palpitation. No history of calf muscle pain, recent surgery, and prolonged bed rest. Past history, recently diagnosed type 2 DM and systemic hypertension on lifestyle modification. No history of similar complaints in the past. No history of transient loss of consciousness or transient blurring of vision in the past. Family history. Father had a stroke and died at the age of 74. Brother has hypertension and medication. Drug history. Sir. Drug history, type 2 DM and hypertension, diagnosed 3 months back and on lifestyle modification. History of hypothyroidism 4 years back, now not on any drugs. Personal history, fixed diet, normal appetite, sleep sound, bladder now on Foley's catheter, otherwise normal, bowel normal, no history of smoking or alcohol intake. Socioeconomic history, she is a homemaker by occupation and education is +2. Congregated house with 4 rooms, 2 persons, 1 earning member in family, income 50K per month, upper middle class. Summary, hypertensive diabetic female with sudden acute onset left side paralysis, including the upper half of left side of the face. No surgery for sensory deficits.
Sound is getting broken in
Sir.
Your sound is
Sorry,
getting...
sir.
It's not your issue, it's some connectivity issue. Okay, carry on.
Okay. A hypertensive and summary. A hypertensive and diabetic female with sudden acute onset of left-sided hemiparesis, including the lower left side of face, No history suggestive of sensory deficits or any cranial nerve involvement other than UMN lesion of 7th cranial nerve on left side. History suggestive of acute neurological deficits, probably a vascular event in the right side of brain.
Okay.
Next. General examination.
Yeah,
Patient
wait.
and
Hello? Hello?
Sir.
From the history along, we have discussed to some extent, okay? And then we'll go to examination.
Okay, sir.
So
Okay, sir.
just go to the first slide itself.
Chief complaints.
Chief complaints. So it's a like according to you, it's like a sudden onset weakness of the left upper limb and lower limb, and the angle of mouth deviation to right side and slurring of speech. Can you just elaborate on the each complaint? First of all, you're saying
Patient presented with.
First of all, you're saying actually sudden onset. So what are actually the possibilities in our in this sort of scenario? Like what are actually the sudden onset symptoms in neurology? What are the usual causes? Sudden onset. If
Sudden
something neurology. Okay.
Hemorrhagic event.
Okay. You can't tell like any actually trauma or this thing or vascular event. Vascular events are actually sudden in onset. Okay,
Sudden in onset.
And are the ones which can be sudden in onset in neurology. So if you have a patient of sudden onset left side hemiparesis with angular mouth activity right side and dysarthria, means what are actually the possibilities? With this complaints alone, what are the possibilities?
Sir, sir, it can be a cerebrovascular accident.
Cerebrovascular accident. It can be a ischemic stroke in the right side of the brain, or it can be a hemorrhagic stroke in the right side of the brain. Both can actually present in the similar. Understood?
Okay. Okay, sir.
This symptom complex only we can tell for this for sure. It is either a ischemic stroke or a hemorrhagic stroke in the
Hemorrhagic stroke.
In the actually right side of the brain. Okay. Okay.
Right.
Go to
Okay, sir.
Next slide, please. Next slide. Next slide.
Instead of presenting plates.
HOPI. Just move to next slide.
Past history.
This you are going to the past history. Actually, you have to write the history of present illness. History of present illness, you have to write each symptoms detailedly. That is called the history of present illness, which is missing here. After actually the chief complaints, next slide should be the history of present. Each complaint you have to
History of presenting complaint.
So that each complaint you have to elaborate and write in the HOPA or the history of present illness. Okay, this should be the second.
Sir.
Should be the second slide, not the negative history. Should come later.
It is the second slide, sir.
Okay.
It is the second slide.
Just tell each line. Recently diagnosed.
Patient.
That you have to bring in the past history, not in the HOP. This diabetic hypertension. That you have to
Okay, sir.
Anyway,
okay.
Patient woke up
Patient
normally.
woke up normally on 16th July and prepared the breakfast.
After actually having breakfast only, she developed suddenly these symptoms together. Right. Because I can notice the husband. Patient also had difficulty in walking. So this difficulty in walking is due to what? Most likely in this context. It is due to her
weakness.
Okay. What weakness? Right leg weakness. Okay. Right lower limb weakness. She had difficulty in walking. Right. Since she had right side weakness, this difficulty in walking is most likely due to the right side of lower limb weakness. Okay, climbing stairs also is
Okay, left side
left side. She's okay. Hello.
weakness of the lower limb.
Side. Left lower limb weakness. She has actually difficulty in walking. Understood. Okay. Climbing stairs difficulty
Yes, sir.
due to left lower limb weakness. Lifting the left hand over the knee is due to left upper limb weakness. Gripping her slippers in the left due to the
Proximal muscle,
left lower limb, like distal
distal muscle.
foot weakness. Foot actually gripping
Okay.
due to the adductors of the toes. So adductor toe also is weak. That's why she has actually
Okay, sir.
difficulty in gripping her saying the chapel in her left foot. No difficulty in holding a glass of water with her left hand or right hand, you want to say?
In the left hand, sir.
She doesn't have weakness to, doesn't have any issue with holding the glass. Are you sure?
By her history, she had no difficulty in holding water.
Able to hold, but not in the same manner as in the right upper limb. I think that may be the better fit.
Yes, sir.
She actually
Yes.
able to hold it, but not with that easiness as she is doing it with the right hand. That may be the better term in that context.
Yes, sir. Yes, sir.
Taking foot, that means she's having some power in the left upper limb, but not as much as what she is having in the right upper limb. That gives
Right
a wrong
upper limb.
that gives a wrong message that there is no
history of
okay. Now still involuntary defibrication micturition.
no history of involuntary defecation and micturition.
Okay.
History of trauma or fever.
In the case of stroke, you don't usually get this micturition problem. Why? Because usually micturition, like bladder is actually controlled. Has got actually bilateral denervation. So usually in our
bilateral
bladder is not usually affected. So they don't have much issues with micturition. Okay. Now history of trauma or fever.
Sir.
Go to the next slide.
Yes, sir. No history of headache, vomiting. No history of consciousness. No history of decreased sensation.
Change the slide, please. Okay.
Past history.
No history of headache, vomiting. What do you want to convey with that line? With that phrase, what do you want to?
Any raised ICT symptom.
No history to suggest any raised intracranial tension. That's what you want to convey with that.
Tension.
Okay.
Yes,
Now,
sir.
loss of consciousness and seizure.
No,
that also it is not a large area involving,
not
involving cortical region. That you say seizure means it is not affecting the. It is if it was there, if seizure was there, we can tell that the cortex gray matter is affected. But here we can't say whether it is affected or not. Anyway, unlikely it is affected. That's what we can infer from that phrase. Okay. Now, loss of consciousness usually in stroke. If it is actually the brainstem bilateral pons midbrain affected, we'll have loss of consciousness. Or it is a bilateral cerebral hemisphere affecting the stroke. Bilateral stroke only. Usually we will have loss of consciousness in a case of usual stroke.
Yes, sir.
No history of decreased sensation. Okay. No history of decreased smell, blurring of vision, double vision. What do you want?
No history of
what do you want to convey with that sentence?
No cranial nerve.
No, first cranial nerve, second cranial nerve, third, fourth, sixth cranial nerves are unlikely to be affected. We can't be sure, but with the available history, there is nothing to say that these cranial nerves 1, 2, 6 are affected. So we can tell. No, so decreased sensation for the face and decreased hearing means unlikely the fifth cranial nerve or the eighth cranial nerve is very unlikely to be affected. We can tell like that. No history of difficulty in swallowing and nasal irritation means unlikely 9 to 10 cranial nerves are affected. Right?
9 the cranial nerve affected.
No history of chest pain, palpitation. What do you want to say with that?
To rule out the chance of atrial fibrillation can be
In a case of
presented.
in a case of stroke, atrial fibrillation is a usual culprit for a embolic stroke. So they may or may not have palpitation, but if it is there, we can tell it is likely to be a embolic stroke. If it is not there, we can't be sure. It can be either way. Okay.
Yes,
Now,
sir.
occasionally, MI
Okay, sir.
infection, they will have first initially MI, then they will have some cardiac clot inside the chamber of the heart, and it can get dislodged to the brain and cause embolic infarct. So sometimes actually both MI and then secondary stroke can occur together. Okay, so if
Yes, sir.
there may be a chest pain, but here there is no chest pain, so we can't say it is there or not, but unlikely it is there. Okay. Now if we have
Yes, sir.
calf muscle pain, what do you want to say with that thing? No, that is
Any
venous. You're bringing the venous stroke history here. This is mainly for DVT and all. It is not in the context for a
yes,
stroke. Stroke, you don't get these things in the background. This is mainly for pulmonary embolism.
okay, sir.
I'm saying this line is not needed in this context.
Okay, sir.
Okay. Next slide.
Okay, sir. Past 3. Recently diagnosed type 2 diabetes mellitus and systemic hypertension on lifestyle modification. No history of similar complaints in the past. No history of transient loss of consciousness or transient blurring of vision in the past.
So he has got a lifestyle diseases. Okay, he has got a very likely to be a metabolic syndrome with diabetes, hypertension in young age. So this patient is only 46, right?
48, sir.
48. So if at all is a ischemic stroke in the background of diabetes, hypertension, in below 45 ischemic stroke, we call it young strokes. Okay? But 48 also we can bring in some patients. So if it is a ischemic stroke, this diabetes, hypertension in the background can be the culprit for the young stroke. Okay? If it is a ischemic stroke, okay, metabolic syndrome and all things. If it is a hemorrhagic stroke, hypertension can be the cause. Diabetes has nothing to do with the hemorrhagic stroke. Hypertension is the usual culprit for hemorrhagic stroke, right? No,
Okay.
there's no history of stroke in the past. We can tell like that. No history of transient loss in. What do you want to convey with that sentence? No history of transient loss of
No history of transient ischemic attacks in the past.
there is no unlikely to be a TIA. TIA means in the carotid territory transient ischemic attack or a transient blurring or loss of vision. It's also in the carotid territory. So there is an unlikely to be a TIA event in the past. Okay? No TIA event in the past.
Yes, sir.
Next slide.
Family history. Father had stroke and died at the age of 74 years. Brother has hypertension and on medication.
Okay, so with family history, strong family history of hypertension, father also very likely is a hypertensive and maybe diabetic. You asked about that part, whether father was a diabetic hypertensive.
That patient don't have much clarity about that.
I mean, most of these people don't check in those era. It's common. Okay, so father had stroke, brother has hypertension. So this patient is predisposed very much to for a ischemic stroke and to some part to hemorrhagic stroke also. Okay, more this diabetes hypertension gives the psychic leads the history more to the favor of a ischemic stroke. Understood?
Yes,
okay.
sir.
Okay, next slide.
Next, drug history. Type 2 diabetes and hypertension diagnosed 3 months back and on lifestyle modification. History of hypothyroidism 4 years back, now not on any drugs.
Okay, next slide.
Personal history. So economic history. So,
Your sound is getting broken. Some issue.
sorry. Am I audible, sir?
Okay, now it's audible.
Okay. A hypertensive and diabetic middle-aged female with sudden acute onset of left-sided hemiparesis, including the lower left side of face, no history suggestive of sensory deficits or cranial nerve involvement other than UMN lesion of seventh cranial nerve on left side. History suggestive of acute neurological deficit, probably vascular even in the right side of brain.
Okay. So same thing only. There is nothing more to add. That these things together this symptom complex together lead to a this thing either a ischemic stroke or a hemorrhagic stroke involving the right side of the brain. Since she is conscious, alert, obeying commands, answering questions, doing things as per our commands. It hasn't affected actually the sensorium. It hasn't produced any seizure. It hasn't produced any cranial nerves. It hasn't affected. So where is the most likely to be the lesion in the brain? Anything can tell with the available history. Where is the most likely topography of the event? Can you tell?
It can be in the deeper parts of the brain.
Why not in the pons?
Then involvement of other cranial nerves are seen in pons.
Which cranial nerves can be affected if it was a pontine lesion?
Sixth cranial nerve.
Which all cranial nerves start from the pons?
Pons, seventh cranial nerve.
Oh.
Pontomedullary from pontomedullary junction.
5, 6, 7, 8. 5, 6, 7,
5,
8.
6,
7,
7, 8.
So
Okay.
if right side event, we would have expected some either 5th or 6th or 7th or 8th cranial nerve in the right side can be affected, but not always. Okay. Okay. And then
Yes, sir.
even the third, fourth, the diplopia and all can occur because this fibers go down from the actually the midbrain towards the pons. So even the third, fourth also partially can. Fourth and third can also
Yes, yeah.
can be affected. Okay. So it's unlike
Yes,
why
sir.
not in the right side and medulla?
Medulla, then other symptoms of medial medullary syndrome or lateral medullary syndrome are not seen here. Nasal rigor.
Medial medullary syndrome.
Structures involved in medial medullary syndrome. I think medial medullary syndrome with the involvement of anterior spinal artery and involves
Why in this case it is not in the medial medulla? Medial medulla, the seventh cranial nerve, what you have mentioned here, won't be affected. Okay, seventh can be affected in the pons, but not in the medulla. Okay, so here
yes, sir.
the right side facial palsy, which doesn't occur in a right sided medial medullary syndrome. Okay, other things, left upper limb and left lower limb weakness can be there, but usually in a medial medullary syndrome, if you have seen the case, it will be a dense weakness. Not like this thing is able to hold the glass with the left upper limb and what you have mentioned. That sort of mild weakness usually doesn't happen with a medium. It will be a dense weakness. It will be a severe 0 to 1/5 power in the limbs. Okay, usually. Okay, because it is a medulla is a
Okay, sir.
small structure. If a small impact even can produce a dense weakness. Okay, so
Dense lesion.
usually since actually the fibers are actually closely packed inside the medulla. Medulla is is very small structure, but the the fibers are actually very closely packed. So even a small impact can produce a dense weakness. Okay. So here you are saying from the
Yes,
history,
sir.
is able to hold the glass with the left upper limb and all. That means it is a not a dense weakness. Okay. So it's
Yes,
not a
sir.
dense, it's a mild or even mild to moderate weakness, not a dense weakness. Okay. So why not
Yes, sir.
it is a right-sided lateral medullary syndrome, or what's the other term for lateral medullary syndrome? Wallenberg syndrome.
Wallenberg syndrome.
So why?
Then Horner syndrome. Horner syndrome will be there. Medial lemniscus syndrome.
Tell me.
Then medial lemniscus involvement.
Tell the structure and tell the neurological deficit out of its involvement. So it will give some information to others also. What structures are available? It will produce this this symptoms or signs. That may be more informative.
Medial lateral medullary syndrome. Lateral structures.
Horner syndrome, you told initially. Which structure is affected in the Horner syndrome?
Sympathetic.
Sympathetic tract, it goes along the lateral medulla. So usually in most of the Wallenberg syndrome, they will have some amount of Horner syndrome. Horner syndrome means what all? It's for the others to learn if you are thinking about it.
Ptosis, anhydrosis,
Mitosis,
enophthalmos,
ophthalmos,
meiosis.
meiosis. What do you mean by meiosis? Meiosis? What do you mean? I'm just
Meiosis is the
information. I know you know about it, but then others all may not know. That's why I'm going for it. What do you mean?
Constriction of the pupil.
Yeah, it is a small people
with
generally.
light.
Okay. Okay. So since that is not there, then what other structures are affected, and what will be the neurological deficit out of it?
Other structures in lateral medullary syndrome, sir.
If it then medial meniscus is affected, what will be the neurological deficit?
Medial meniscus, posterior column sensations.
Right. Posterior column means our joint position, vibration, deep touch. Those sensations will be affected in the contralateral side. Okay. If it is a lateral meniscus, what will be the neurological deficit?
Then lateral spinothalamic tract.
Spinothalamic. They will have loss of pain, temperature. Okay. Those soft touch. Those deficits will be there in the contralateral side. Okay.
Yes, sir.
What other factors are affected usually in Wallenberg? They will have usually 9 to 10 cranial palsy, because 9, 10, 11, 12 cranial nerves start from the medulla. Okay. So they will have dysphagia, dysphonia, nasal vegetation. Those all things will be there in the lateral medullary syndrome. Are also usually affected. Okay. So ipsilateral, if it's the right-sided lateral medullary syndrome, they will have right-sided 9th cranial nerve palsy. Okay. Okay. So it will be other things. Okay. So these are the common things in a medullary lesion. So why not it is the right side midbrain stroke?
Then features suggestive of that's not seen involved.
Sound getting broken.
Am I audible?
Now you are audible. I think you have to talk more closely to the mic. Okay.
Okay, sir. In medial medullary midbrain.
Right side midbrain lesion. Why not a stroke involving the right midbrain? That's the question.
Sir, if it is in the midbrain, then features suggestive of Weber syndrome.
Yeah. Means what?
Benedict.
Cranial nerve starting from like
third cranial.
Third and fourth.
Third cranial nerve involvement.
Third and fourth are the
Then,
terminal from the midbrain. Okay.
Midbrain. In Weber syndrome, third cranial nerve is affected, and ipsilateral corticobulbar tract of are affected.
No.
Red
Here-
nucleus substantia nigra are affected, sir.
Okay. So usually they will have a they will have this thing this thing what do you call it? For this thing vertical diplopia due to the third cranial nerve palsy. They will have they might have ipsilateral ptosis. Okay, so right midbrain lesion, usually they will have a right sided ptosis. Okay, okay. Sometimes pupil can be affected. That's it. Pupil may be dilated. Okay, if it third cranial nerve affected, can produce a ipsilateral dilated pupil. Okay, mydriatic pupil. Okay, so and they will have
Okay, sir.
same side like cerebellar signs usually. Okay, they will have severe ataxia is common. Ataxia is common with in all brainstem, including midbrain, pons, and medulla. Ataxia is usually because this brainstem as such is a small structure compared to the cerebrum. Okay, so most of these fibers are very densely packed. So even a small lesion can produce so much deficits, unlike a lesion in the cerebrum part. Okay, so usually most of them will have ataxia to the same side, while they will have weakness and the sensory loss in the opposite side. Okay, and this thing posterior column, lateral spinal spinothalamic affecting cortico, the same cortico, or pyramidal tract all will be affected in the opposite side. Okay, okay. Then why not? This is actually a stroke involving the right side thalamus. If it's a thalamic stroke, what would be the common presentation?
Degeneration syndrome, then burning sensation, hyperalgesia,
initially
hemibalismus, abnormal movements.
Hemibalism not in thalamus, it is in the subthalamus nucleus.
Subthalamus.
Usually thalamic lesion classical presentation is they will have a hemisensory loss and paresthesias in the opposite side. Paresthesias, they will have numbness, burning sensation in the opposite side. Okay, and actually sensory loss in the opposite side, and they also will have some pyramidal tract affection. They will have some amount of weakness. Sometimes weakness can be dense also. Usually it's a mild to moderate weakness. Okay, thalamic.
Okay, sir.
Okay, so here, so it is unlikely to be a thalamus, unlikely to be a right-sided midbrain, unlikely to be a right-sided pons, unlikely to be right-sided medulla. So where else are you localizing in this case?
Internal cap, not basal ganglia. It can be in the
thalamus. What is the structure in the same part of the brain?
What's that?
We are gone from actually below to up. Okay, lowermost portion we told medulla. The next highermost is the pons.
Caudate nucleus.
Okay. Next higher structure in the brain is the midbrain. Above midbrain is the subthalamic nucleus and all, and then comes the thalamus. So we are now going from below to top. Okay. So above thalamus, what are the structures called? Those structures, deep nuclei, deep
basal ganglia.
It is called the basal ganglia. Okay, called the basal ganglia. Okay, so
basal
ganglia is made up of what all structures? Do you have any picture or can you tell abstractly for others to understand?
No picture. Caudate nucleus.
Yeah, in the actually the lateral medial part is the thalamus. In the lateral part, what is the structure dividing this thing? This is the internal capsule. Internal capsule is
internal capsule.
Internal capsule is the what structure? The
projection fiber.
It's actually the white matter tract. It's the white matter tract.
White matter tract.
This thalamus, caudate, putamen, globus pallor, all those things are actually deep actually gray matter nuclei. Understood?
Yes, sir.
They-
Yes, sir.
Gray matter nuclei are actually divided. This position in between comes the white matter tract called the internal capsule. Okay.
Internal capsule.
Capsule. Then the uppermost part is the caudate. Then you have putamen and the globus pallidus. Okay.
Globus
Okay,
pallidus.
Okay. This thing. So.
Okay.
So in this case, where is the most that is the area which is most likely to be the culprit. Okay, localizing. Okay.
Yes, sir.
It is in the in cortex or the just subcortical structure. What are things against this thing? Against a cortical?
No aphasia, sir. No seizures.
Aphasia. We're talking about language problem. We are now dealing with a right hemispherical lesion, right sided brain lesion. Okay. Aphasia usually occurs in the left sided brain because our
Yes, sir. Dominant side.
of us,
Dominant.
most of the speech area is in the left side. Here we are talking about the right side hemisphere brain. Okay.
Apraxia, parietal lobe involvement, constructional apraxia.
That is only after examination. Anyway, the available thing, there is no actually consciousness issues. There are no seizure. Okay. And this thing, patient otherwise is well obeying commands. There is no language problem actually. It's cognition is not much affected as per your history. So it's only and only pure motor weakness in the left side. Okay. And some facial palsy. Okay. And dysarthria along with the facial palsy. So there is no other symptoms, but your from your history favors any cognition issues. So or any saying if it has a occipital lobe involvement, you would have got some visual symptoms. Okay?
Visual agnosia.
There are many visual symptoms. Okay,
prosopagnosia.
You are told only about actually the saying pyramidal tract in your history. So it's unlikely to be unlikely. It can be every time sure, but it is unlikely in the cortical structure. So most likely in this patient with hypertension in the background, it can be either a ischemic stroke involving the right basal ganglia or a hemorrhagic stroke involving the right basal ganglia.
Right basal ganglia.
So what do you think more likely when the available history? Is it hemorrhagic stroke or a ischemic stroke?
It was a sudden progressive in sudden in nature.
Both start suddenly. Onset is almost same. So
then a maximum weakness is at the onset in case of hemorrhagic stroke.
A little. Ischemic also it is same only. It is maximum deficit supposed to be in the onset time. I mean, it's like difficult. It's 100%. It's not like this thing. You can differentiate, but some clues are there in favor of it. Maybe hemorrhage. It may be ischemic. That's what I'm asking. Which are the symptoms favoring a hemorrhagic stroke? I mean, it is not here the thing, but if you know,
and headache, vomiting, loss of consciousness.
Okay. Headache usually is seen in a hemorrhagic stroke, but some ischemic stroke like large MCA infarcts, large actually cerebellar infarct can have headache. Cerebellar infarct can produce actually occipital headache.
Yes. Brain edema.
Temporal region or in the frontal region they can have headache. It should be a large MCA infarct. Okay, but large MCA here unlike large MCA situation will be very restless, drowsy, unconscious and all. Okay, but here patient is very concerned. It's that large MCA is completely ruled out in this context. And cerebellar stroke, there is no attention. So, but in a basal ganglia, you say and all in most many a times headache is seen in hemorrhagic strokes. In only few ischemic stroke, headache is one of the actually the presenting symptom. Understood? And
Okay, sir.
vomiting also more commonly seen with the hemorrhagic stroke, but some ischemic strokes like that can cause raised ICT like large MCA, cerebellar brainstem stroke can present with vomiting. Other usual basal ganglia ischemic strokes usually don't present with vomiting. If it also it's only due to aspiration or something, not the common initial presenting symptom. But many a times hemorrhagic problems actually frequently present with vomiting. And in hemorrhage stroke, usually
Yes, sir.
presentation symptom and presentation BP will be very high. In ischemic also it
Very
is high.
high.
Ischemic also it is very high,
Yes.
but in hemorrhagic we can tell it
Yes.
is very high. Okay, maybe more
More
than
high.
200.
Okay.
Uh, systolic is a common presentation BP in case of a hemorrhagic stroke. While ischemic stroke, it may be 180, it may be occasionally 200. Beyond 210 and all, it is not common. Can happen. That's one of the
Yes.
other actual differentiating point between ischemic and hemorrhagic strokes. Other thing is
Okay, sir.
same. Other thing is one common thing is that usually is the hemorrhagic stroke usually actually starts in actually the starts at daytime. While ischemic stroke can be in
Daytime.
or night time. We can have
Early morning.
wake-up strokes and all are quite common. But ischemic, I mean, the hemorrhagic problems usually happens when this thing, patient is active during active working time.
Yes.
You should develop this thing. BP gets shoot up and it will end up in a hemorrhagic stroke. Understood? Nighttime
Yes, sir.
hemorrhagic stroke is very rare. Okay. So these are the
Yes, sir.
always possible to differentiate, but the available information I'm telling you. Okay. Okay, carry on.
Oh, okay, sir. Next,
So you can go to the next slide.
general examination.
Hmm.
Patient is conscious and oriented to time, place, person, moderately built and nourished, no pallor, cyanosis, clumping, lymphadenopathy, edema, vitals, pulse rate 8 per minute, regular rhythm, normal body and character, peripheral pulses palpable, no radiofemoral delay, no radioradial delay, BP 170/100 in right upper limb in supine position, respiratory rate 20 per minute, abdominal thoracic type, temperature 98.6 °F in right axilla, higher mental functions, right 100%, knows Malayalam, conscious and oriented time place person, E4, V5, M6, normal appropriate appearance and behavior, patient is emotionally stable, normal calculation, speech, normal fluency, normal comprehension and repetition, able to read and follow, cranial nerve examination, olfactory nerve, normal on both. Okay. The power is sir, olfactory, optic visual acuity, normal, visual field normal, and pupil is round and reactive. Color vision is normal. All cranial nerves are normal except cranial nerves are. Sir. Sir, am I audible?
Yes.
Okay. Cranial nerve, all cranial nerves are normal except for the lower, left lower half of facial nerve. Then image showing deviation of arm of
Rashmi, just 1 minute. I think sir has left. Sir has
muted.
Sorry. No. I'm hearing you.
Okay.
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 Hmm.
Sir, motor examination. Attitude of the patient. Patient is supine with shoulder adducted, flexion at elbow, flexion at wrist and semi-pronated arm. Lower limb left is externally rotated with extension at the hip and knee. Bulk is normal, sir. The picture of the patient showing attitude of the limb with external rotation at the hip and knee. Then tone, hypotonic on left side and normal on the right side. Then power is 3/5 in left side and 5/5 in right side. Then pronated drift sign is present. That is on keeping both upper limbs outstretched for some time with palm. There is slow pronation on affected side. The video illustrating the pronated drift sign.
This is not the proper pronated drift sign. You have to keep the arms in like this.
Sir.
Are you able to see me?
Okay, sir.
Then that
in supine position. Okay, sir. In supine, sorry. Then reflexes, superficial reflexes are present and plantar is extensor response. Video showing extensor plantar. Next, deep reflexes. On left side, it is sluggish. On right side, it is normal. And sensory system. All sensations are intact. Dorsal column, spinothalamic tract, cortical sensations are intact. Cerebellar functions are normal. No signs of meningeal irritation. Examination of spine is normal. Auscultation of neck. No carotid bruit heard. Other systems are also normal. CVS, no carotid bruit, no murmurs. Respiratory system, normal vesicular breath sounds, no ardent sounds. Abdomen, soft, non-tender, no organomegaly. Provisional diagnosis, clinical hemiparesis of left upper limb and lower limb. In neuronal shock with left-sided UMN type of facial palsy. Anatomical, right side of the brain involving basal ganglia. Etiology, hypertension and diabetes mellitus. Then here it is the MRI and CT of the patient showing hemorrhagic stroke in the right side. Sir, am I audible? Hello, sir.
Yes.
Jipu-san. Excuse,
Okay.
sir.
Right. Okay. I think you finished. Here there are some connectivity issues. No, it's okay.
Okay, sir. Patient video of walking. Able to walk now, sir. Then circle of some added informations.
No, those things you bring it late. Now you finish off the case and then we'll go for discussion. Otherwise, it will.
Yes. Yes. Provisional diagnosis. Hemiparesis of left upper limb and lower limb in neuronal shock with left-sided UMN type of facial palsy. Anatomical. Right
Wait,
side of the brain involving basal ganglia.
wait, madam. I think you go to the first slide after the this thing. Okay, examination. Just start examination part. Then we will each slide by slide. Just go through fast. Then we will come to the diagnosis slide.
General examination.
Yeah. Examination where is okay. Patient consciousness. Okay, next slide. And that
Patient is conscious.
vitals. Vitals is in the first slide.
Vitals. Pulse rate 88.
In a case of stroke, like which part of this vitals we are more interested?
Pulse rate and BP.
Pulse rate, more than pulse rate, we are bothered about actually the
Rhythm.
Yeah, rhythm. Whether it's irregular, because atrial fibrillation is a common cause for embolic stroke. So
Yes, sir.
irregular pulse or not is a main thing which we are bothered in a case of a stroke, in a ischemic stroke. Okay. So here
Yes.
you are taking it is regular pulse. Okay. And then comes the next is the BP. BP is 170/100. This 170/100 presentation in a case of a stroke is more in favor of a ischemic stroke. Okay. But it
Ischemic stroke.
can happen in hemorrhagic also, but when a patient suddenly present with hemiparesis and not to have 170 BP, we usually think with that BP more in favor of a ischemic stroke. Okay. And okay, next slide. So hemorrhagic stroke, as we told earlier, usually BP will be much above 200 value for a systolic BP. Okay. And the mean arterial pressure usually will be more than 110 and all in a case of a ischemic stroke.
Okay, sir. Higher mental functions.
You know how to calculate mean arterial pressure?
Mean arterial pressure, 2/3 of diastolic pressure plus 1/3 of systolic pressure.
Okay. 1/3 of systolic.
1/3 of diastolic, 2/3.
Okay. Tell me like that. If it is a 120/80 BP, what is the mean? Okay, mean arterial pressure.
120.
120/80.
60. 60 plus 20, 80, sir.
120, 80, 80 is the diastolic pressure. We are talking about nothing. Anyone in the crowd can tell? Hello.
100, sir.
How will you calculate it? This is a diastolic plus 1/3 of the pulse pressure. So 80 plus 40 minus 40 divided by 3, that is around 13. So 80 plus 13 is 93. So 93 is
Nine.
the
Pulse
arterial
pressure. Mean arterial pressure. Okay.
Okay, diastolic BP plus 1/3 of the pulse pressure. Pulse pressure is systolic minus diastolic.
Systolic minus diastolic.
Okay. So usually in a hemorrhagic stroke, it is very commonly more than 1/10.
Okay, sir.
Okay. So okay. And this thing you're telling speech, normal fluency, comprehension, and repetition. Okay. What are okay? Anyway, for just to see, what are the parts which we check commonly in a speech? Speech, actually, speech is not speech; it's a language.
Language.
So-
Sorry. Language, sir.
So writing here speech, you should have written language. Okay.
Okay.
So what
Okay,
are the
sir.
common things which we check in language?
Fluency, comprehension, repetition,
Naming.
yes,
പിന്നെ writing, reading, copy.
right, yes,
Seven
yes,
things. Okay, 7 things. So in a broadcast aphasia, comprehension will be the comprehension
normal,
preserved to large extent.
preserved.
While in a vertical aphasia,
Okay,
much affected. Okay, that's a common.
yes, sir.
Okay, good. So this thing, speech, we mean either these are three of those other actually, okay, other mechanical parts or language. So language specifically are talking about a higher mental function part of the speech. Understood?
Yes, sir. Yes, sir.
Okay, next.
Cranial nerve examination, olfactory, normal on both sides, optic nerve, visual acuity, pupil, color vision are normal, fundoscopy not done, oculomotor, trochlear abduction, light reflex, both direct and indirect, normal, present, extraocular movements are normal, trigeminal, sensory and motor part are normal on both sides, facial nerve on left side, deviation of angle of mouth to right, inability to puff out cheek, absence of nasolabial fold, others are normal. That means be able to close the eyes and forehead wrinkling are normal on both sides. And on right side, ability to puff out cheek also present, nasolabial fold present, anterior two-third taste present. On vestibulocochlear, normal on both sides. Glossopharyngeal and vagus, normal on both sides. Then image showing TB of mouth to right.
So facial, okay, just quickly for others. Hello? Hello? Hello?
Yes.
Hello?
Hello, sir.
I think she's not audible, right? Hello?
Hello, sir. I think she just lost the connection.
Okay.
Hopefully she will join soon. So she lost the connection and she's actually trying to reconnect. I'm trying to make it fast. Sorry for that. Yeah, you are audible.
Okay.
So there might a issue regarding the laptop. So she will be continuing through mobile.
Now, cranial nerve involvement. Only on the left seventh cranial nerve is affected on in the lower half. Then motor examination. Attitude of the patient. Patient is supine with shoulder adducted, flexion at elbow, flexion at wrist, and
Power-
semi-pronated arm. Hello?
PowerPoint you put on the screen.
PowerPoint, sir. എന്താണ് അത് ശരിയാക്കിക്കൊണ്ടിരിക്കുന്നു സാർ.
Oh, correct.
കണ്ടിന്യൂ ചെയ്യണോ ഇപ്പൊ ആദ്യം അത് കറക്റ്റ് ആക്കിയിട്ട് മതിയോ?
No, continue. Otherwise, people may get bored. Can I show you if you
സിസ്റ്റം
can?
ഷട്ട് ഡൗൺ ആയി.
Oh, okay.
നോക്കട്ടെ, ജോയിൻ ചെയ്യാൻ പറ്റുമോ നോക്കട്ടെ സാർ. മീറ്റിംഗ് ഐ ഡി.
Anyway, continue with the time being with your mobile. Otherwise, it will be a long gap.
ഇതിനകത്തുണ്ട്. സാറിന് കഴിച്ചിട്ടുണ്ട്. അതിനെന്താണത് ഇരിക്കുന്നത്? Yes, sir. One minute, sir.
So you can try sharing from your phone itself. Mithun, Rashmina co-host ആക്കിയാൽ മതി.
Srilashma, I think you can share slide through the Zoom account that you are using in this current mobile. I made that mobile as a co-host. Srilashma, just unmute yourself.
സ്ക്രീൻ ഷെയർ ചെയ്തില്ലല്ലോ. ഷെയർ ചെയ്യാൻ Sorry, sorry for the inconvenience.
Okay, you um,
Excuse me. Shall we continue?
yeah.
Okay. Cranial nerve, all cranial nerves are normal except for the seventh cranial nerve in left lower half.
Okay,
Then
why
auto
is
examination, attitude of the patient.
Srilakshmi, can you hear me?
What, sir?
Okay.
Sir.
Asking
Yes, sir.
why it is not a LMN cranial nerve palsy according to you?
Because only the opposite lower half is involved.
More than
By seventh
uh, from
cranial nerve has bilateral innervation on the upper side and only ipsilateral innervation in the lower half.
from the history alone, how can you say it is definitely a human facial palsy and not an LMN?
History
അല്ല,
patient is able to close the eyes.
okay, that's one thing. Other thing is that dysarthria along with facial palsy. Okay, dysarthria along with facial palsy in this context tells it is clearly human. Okay, in a LMN facial palsy, that same facial palsy doesn't produce dysarthria. Okay, so here the facial palsy has produced dysarthria also. So both things occurring together, with it is very likely to be human. Okay, in a plain actually LMN facial palsy like in our actually is the usually we get LMN facial palsy and actually Bell's palsy. Bell's palsy there is no dysarthria. Understood? Okay.
Yes, sir.
So in a human
Yes,
facial
sir.
palsy we encounter facial palsy and clearing your speech together. Okay, that's one thing. And
Yes, sir.
spice and other things are all will be normal in a human facial palsy. Well, it will be
Yes, sir.
facial palsy. Okay. Okay, carry on.
Shoulder action, flexion elbow, flexion at wrist, and semi-pronated arm. Lower left is externally rotated with the extension at the hip and knee. Bulk is normal.
I don't think you play the video.
Video and the attitude, sir. No video here.
Okay. So what is abnormal in this thing and why it is abnormal according to you?
Here,
Which
anti-gravity muscles of the lower limb have more weakness in cerebrovascular accident. So here, external rotators have more weakness. Sorry, internal rotators.
explain properly to others who don't know what is happening here. You just tell what is a normal posture and why there is abnormality and why it is abnormal. Okay. Normally when we can I is my mouse seen to all of you? I am now moving the mouse. Can anyone see it? Hello.
No, sir. This is
I am not trying to move my mouse here. I think your mouse alone is in. Can you do the
yes.
settings so that my mouse movement also is seen in the screen to everyone? Can you make the settings like that? Then only I'll be able to show these pictures properly to others. Hello? Hello?
Hello?
Admin of the...
Sir, I made you co-host. Now you can share.
Okay. So now it is visible to others. I am moving mouse in that picture. Is it visible to others?
സാറിന്റെ
No.
സ്ക്രീൻ ഷെയറിംഗ്
എങ്ങനെയാണ് ചെയ്യുന്നത്? How to do it so that
we have to share screen from your SARS laptop. Slide should be uploaded from your side.
Stop other screen sharing. Do you want? Okay, then I will like this will stop other screen sharing. Do you want to continue? Okay.
Yeah.
Shall I put yes? Okay. Fair. Is it seen?
At one time, I think only one person can share the slide, share the screen, sir.
Do one thing. You actually finish off the thing. That afterwards I will show. Okay. Then I will put the stop share. I will put stop sharing. Okay. You only carry on. Is it mine or yours? You now continue. That's better. Afterwards I will show. In the end I will show.
Okay.
Hello.
Hello.
Let me carry on. You only share the screen. Afterwards, in the end, I will show these things, and that I will make it so that I will be able to share the screen, and then I can show these things in the picture. Understood?
Okay, sir.
Okay. You carry on. And then I will show. Continue.
Okay. Then tone of the patient. On left side, it is hypotonic, and in the right side, it is normal tone. And power is 3/5 on left side and 5/5 in right side. Then pronated drift sign. On keeping both upper limbs outstretched for some time with palm, there is low pronation on affected side. Then reflexes, plantar left is extensor response.
PowerPoint is not seen to others. I'm not able to see.
Okay.
Please enable screen sharing.
Okay, sir. Is my presentation visible to all?
Yeah. Srilakshmi, it is visible. Please continue.
Okay. Extensor response. Then deep reflexes, deep tendon reflexes. It is sluggish in left side and normal on the right side. And sensory system. Dorsal column intact, spinothalamic column intact, cortical sensations intact. Cerebellar functions. Nystagmus not seen, titubation not seen, finger nose test normal, finger to finger test normal, dysdiadochokinesia not seen, intentional tremor not seen, dysmetria past pointing not seen. No signs of meningeal irritation. Examination of skull and spine is normal. Auscultation of neck, no carotid bruit heard. Other systems, CVS S1, S2 heard, no murmurs, no carotid bruit heard. Respiratory system, normal vesicular breath sounds, no sounds. Abdomen, soft, non-tender, no organomegaly. Provisional diagnosis, clinical hemiparesis of left upper limb and lower limb in neuronal shock with the left-sided UMN type of facial palsy. Anatomical, right side of the brain involving basal ganglia. Etiology, hypertension, diabetes mellitus.
Why you told neuronal shock? Explain.
Neuronal shock. Now the tone is reduced, hypotonia in affected side, and all the reflexes are reduced.
Reflexes usually won't be reduced. That is your some
Deep
examination.
tendon reflexes.
Deep tendon reflexes are usually normal. They won't be sluggish or absent in a case of human facial palsy. Okay? That you'll see in LMN weak, lower motor neuron weakness. We expect the deep tendon reflex to be absent or reduced. Human upper motor neuron lesion, we expect it to be normal, or in the later stages, once it becomes spastic, it will be hyperreflexia or spastic. The same. Usually in an acute stage also, it won't be lost. But hypotonia is the one you can argue in that favor. Hypotonia will be there in the initial
Hypotonia.
initial weeks to months. It will be hypotonic. Then after few months in strokes, they'll become spastic.
Spastic.
Okay, the same. So, anatomic right for the basal ganglia, etiology, hypertension, diabetes. Okay, go back to slide. You show them. You got the video of plantar.
Yes, sir.
Then show the others. That's why you brought it. It's not done properly. You should go laterally, and you should stabilize the angle joint, which you are not doing. You have to stabilize the angle joint. Make sure that the patient doesn't withdraw the lower limb. You take control of the angle joint, hold it firmly. Okay, and then actually divert the attention of the patient, and then stroke the plantar. You have to go laterally from down, then go laterally, then come upmost, and actually go medially towards the ball of the great toe. Here you are not doing the proper manner. And other thing which others are not mentioned, here the right lower limb is placed properly. When we lie down, the lower limb will be like what she is having in the right side, while the left lower limb is externally rotated because it is weak. So usually in a weak lower limb, it will be placed externally because the internal rotator of the hip and the external rotator of the hip. Internal rotators will be more weak than the external rotator in the case of a pyramidal weakness. So the weak limb will be externally placed. So seeing the posture of the limb only, we can tell that limb is weak. Here we are talking about the lower limb. Lower limb posture itself is, which is the weak limb. If both limbs are weak, both will be externally rotated. So
Okay, sir.
seeing the left lower limb posturally, we can tell it is the weak limb. Okay. Okay.
Okay.
What else you have? Go back to slide. Go back. That arm sign also you are not showing it properly. You play the video. This is not the way of the thing. This you are not showing arm. Which sign are you showing by this thing? That's not the way that you have to keep your. If people can see me, like this is how you have to keep the limbs. And if my right lower limb is having pyramidal weakness, that will go medially and down. Okay, in case of a
Okay.
this we will do to elicit a mild pyramidal weakness. Ask the patient to keep both upper limb, place it in the same horizontal level, and which limb will get pronated. It will be then get gradually placed below the normal level, and it will go like this thing. So
Oh,
not like this thing, but you have kept. You have to keep it in this manner.
okay, sir.
It's called the arm
Okay, sir.
drift sign or the pronated drift sign to elicit my minimal or mild weakness in the upper limb, which is the sign is used. Okay.
Yes, yes, sir.
Any other go by? Okay. Okay. That face thing, face here, so face picture. Okay. So what are any you haven't taken proper picture. Anyway, anything? Have you got a better picture?
No, no, sir.
You should be knowing how to take and what to take. Anyway, like what is available from the available information, can tell that the right side nasolabial fold is a sharp angle, while the left is somewhat blunt. So it shows there is likely to be a left facial weakness. But you have to take a better picture. It's not that clearly seen. And angle of mouth deviation also not well seen in this picture.
Yes, sir.
Okay. Okay. Any other? So angle of mouth will be deviated to the opposite side of the weakness. If a patient is having a right side facial weakness, angle of mouth will get deviated to left side. Okay.
Left side.
Okay. Mm. Mm.
CT of the patient. CT and MRI.
So any other additional information you could get after doing the examination, apart from what we have discussed in the history? Did you get any other additional information? That's what my question is.
Additional history findings are consistent with the
Consistent
examination.
how we become wiser after examination or not, or we are in the same wisdom level after what we had after um, history. So in the examination, have you got any other additional information?
History findings.
They-
Examination findings are agreeing to
agreeing
history.
that I too agree. Have you got any additional information? Understood my question?
At least,
No, I don't think we haven't become any anything. We haven't gained any other additional information after examination, right? All things were same as what we had in the history level only. Okay. Okay. Then we'll go to CT scan. Okay. This is a CT scan of the patient. I think
yes.
you hand over the thing to me, then I will share the screen. Then I can give more information. Otherwise,
Sir, I think,
I have to,
sir, I think, സാറിന് അത് ഷെയർ ചെയ്യാതെ പറ്റുമെന്ന് തോന്നുന്നില്ല.
okay. Then I will share. Okay, and this will show for others. Do you want to continue?
അങ്ങനെയല്ല.
Okay. I will do the sharing. Okay.
No, sir, PPT.
PPT എൻ്റെ ലാപ്ടോപ്പിൽ വേണോ? You ask the admin.
സാറ് ഫയൽ PPT സാറ് ലാപ്പിൽ വേണം, എന്നാലേ അതിന് ഈ PPT മാർക്ക് ചെയ്യാൻ പറ്റും.
Okay, then Any other means it is possible? No.
സോറി സാർ വേറെ വഴിയില്ല.
Okay.
ഫയൽ അയക്കുകയാണ് വേണ്ടതല്ലേ?
I had asked her that like I should be able to show it. Then she told I can do it that way. Okay. Okay. Then you continue.
Next is some informations of hemorrhagic brain hemorrhages. Walking, video of patient walking.
That you should have brought earlier, not now. Okay. And in this video, what are you seeing? Explain what are the findings that you are seeing.
Patient is walk with support and drum of the affected lower limb.
Tell.
The circumcision. Sir,
Keep telling.
sir, posture of the patient, gait of the patient, circumduction, gait.
You are not showing any circumference anywhere. You saying video is not playing. So when she is walking, you can see the right lower limb is placed properly. She will keep the right foot in the proper manner. Right left foot is, you can see, externally rotated. It is thing, and once she is walking, she will put her body gravity body weight. Actually, she will try to stabilize it with the right lower limb, and then take the left lower limb. Okay, that normally when we walk, both sides are having equal involvement. Okay, even though we are our right lower limb may be somewhat dominant than the left dominant, but still during a movement, both will have nearly normal duties. But here, when she walks, the right lower limb is taking the bulk of the activity. Okay, it is trying to stabilize the body. Okay.
Yes.
So you show a proper video, then only this can be better explained. Okay. Anyway, next slide. Next slide. Should be knowing how to take proper videos and photos. Then only it will be more informative for us.
Causes of intracranial hemorrhage. Head trauma, hypertensive hemorrhage, transformation of prior ischemic infarction, metastatic brain tumor, coagulopathy, arteriovenous malformation.
Wait. What are you saying? Slide is not saying. Okay. I told you to change it as intracerebral hemorrhage. Still it is intracerebral. So these are the cause for intracerebral hemorrhage. Intracerebral means inside the brain bleeding. It can be so in
head trauma here.
Wait, madam. Before that, in our patient is having a hemorrhagic stroke. That CT scan was showing a bleed in the right basal ganglia, right putamen region. So that she's hypertensive, uncontrolled hypertension. So she had a right putamenal hemorrhage, which has produced a left-sided hemiparesis. So that is the final diagnosis for our patient. Okay. So now she's coming with the causes of intracranial hemorrhages. There are different types of intracranial hemorrhage, out of which we are now mainly concerned with intracerebral. So it can be either inside the brain, that is intracerebral, or outside the brain, inside the skull. That is the other cause of intracranial hemorrhage. So for the
Sir,
other
here intracranial hemorrhage, head trauma is a cause for intracranial also.
yeah. The trauma can
Sub-
produce both intracerebral, can produce extradural hemorrhage, can produce subdural hemorrhage, can produce subarachnoid. All causes of bleeding can occur in a trauma. Okay.
Yes, sir.
Okay. So commonest cause of pure intracerebral hemorrhage is hypertension.
Hypertension.
I mean, we can tell out of 100 intracerebral hemorrhages, 60 or 70% are hypertensive bleed.
Hypertensive.
Like in our patient is having a right putamen is a part of the basal ganglia. So right basal ganglia intracerebral hemorrhage due to uncontrolled hypertension. Okay. So
Yes, sir.
common sites for hypertensive intracerebral hemorrhage, commonest site is the putamen or the basal ganglia. Putamen is a part of the basal ganglia.
Thalamus.
Second commonest cause is the thalamus. First I told, most common is the basal ganglia putamen. Second is the thalamus. Third is the
Cerebrum.
cerebellum.
Cerebellum.
Cerebellum is the third cause. Third commonest site for hypertensive intracerebral hemorrhage. Fourth is the pons. Fifth is lobar hemorrhage. Lobar means it can be either in the frontal, temporal, parietal, or the occipital. Okay. So these are the 5 sites for hypertensive intracerebral hemorrhages. Commonest is putamen, second thalamus, then comes
Thalamus. Cerebellum.
I think the same. I only will talk better now. Okay.
Okay.
Just me.
Okay.
Hold on, that's better. Okay. So these are the 5 sites for hypertensive intracerebral hemorrhages. So then other causes of intracerebral hemorrhages are trauma is always a cause. Trauma can cause bleeding anywhere inside the skull. Okay, inside the skull, like I told you, intracerebral or extra outside the brain, inside the skull. Other sites are outside the brain, inside the skull are it can be the subarachnoid, beneath the arachnoid membrane, or it can be subdural, beneath the dural membrane, or it can be the epidural, okay, outside the dura. Okay. Now, or it can be mixed picture. They can have both intracerebral along with epidural, and then subdural or polycytes mixed. Any combination can occur in a traumatic bleed. Okay. Then this thing, ischemic strokes can then actually have hemorrhagic transformation. They initially a ischemic infarct, and then especially embolic infarcts can have hemorrhagic transformation. Okay. Metastatic brain tumors are also a common cause of hemorrhage inside the brain. Okay. Metastatic tumors. Coagulopathy, patient taking heparin, especially thrombolysis with alteplase or tenecteplase, patient taking oral anticoagulants like warfarin, fumarin, or newer oral anticoagulants like rivaroxaban, apixaban, and all. They are all prone to have bleeds. They'll be usually diffuse, multiple sites, bleeds occurring at the same time. Can you see? And some drugs, cocaine and all that thing. Arteriovenous malformation. Okay, AB malformation, when there is no proper capillaries directly from artery to vein, there is a connection there. Prone for rupture of this AB malformation and produce bleed inside the brain. Okay. This thing, aneurysms are common, like they allow. Okay, this thing, aneurysm means the elastic membrane is lost. They'll have bulging of the brain, and they're very commonly seen in the bifurcation points of in the circle of Willis. This aneurysms are prone for rupture. Okay, they can be a massive, sometimes catastrophic hemorrhages can happen with aneurysm rectus. Amyloid angiopathy, amyloidosis can produce amyloid collections. They are also prone for multiple diffuse small bleeds in the multiple sides of the brain. Cavernous angioma, it's a localized cavernoma. It can rupture. Usually, it's a small bleed usually in the cortical areas. Very rarely fatal. Okay, very rarely fatal. Usually, it's a small bleed can present as a seizure if it is in the cortical region. The cerebral sinus thrombosis, cerebral venous thrombosis can produce localized bleeds inside the brain. Telangiectasis, of course, can. Next slide. Next slide.
Yes, sir. Ah,
Next slide.
okay, sir. Okay, sir. Once.
Your battery is running low.
Yes.
Mr. Vireshna, are you there? Mr. Vireshna, are you there?
Subarachnoid hemorrhage. Picture showing hemorrhage. CT scan.
Next slide. Okay, this is a picture of the subarachnoid hemorrhage. You can see blood. That's a hyperdense, bright white thing is the blood. Okay, it is there. Previous one, subarachnoid hemorrhage. Read me.
Sir, subarachnoid hemorrhage.
Okay, so this you can see in this thing blood going everywhere through the sulci, through the sylvian fissure, through all fissures wherever it is possible, this thing extracerebrally, wherever in all this ambient system, interpeduncula system, all those systems where the spaces in between the brain tissue, all these areas are filled up with the blood. In the hemispheric fissure, anterior and interhemispheric fissure, so blood getting actually extravasated through all this like subarachnoid space. So this is a typical picture of a subarachnoid hemorrhage. So what will be the patient having clinical symptom in a typical subarachnoid hemorrhage? If it's a spontaneous aneurysm ruptured spontaneous subarachnoid hemorrhage, what is the typical clinical picture of the patient?
Severe headache.
They will usually present with a thunderclap headache. Okay, they present with severe headache, vomiting. Then examination wise, what are they will have next they will have all positive meningeal signs. Okay, next stiffness will be there. Okay, once it is subarachnoid extension, they will invariably have neck stiffness. So if a patient presents with suddenly with severe excruciating thunderclap headache, vomiting, altered sensorium, low GCS, obtended, okay, then you have to examine for the meningeal signs. The thing is examine for the neck stiffness. If that is also present, you can and they'll be usually having very high BP. Even if not hypertension, also they will have reactive hypertension. BP will be usually more than 180 or 200. Okay, that context check for the neck stiffness. If that is also present, we can tell most likely it is a spontaneous subarachnoid hemorrhage, because no history of trauma or any other reason to produce subarachnoid hemorrhage. So it's a spontaneous subarachnoid hemorrhage. Usually it occurs as a result of the aneurysm rupture. Okay. So patient has to be sent for the clipping or coiling of the aneurysm at the earliest, along with giving vasodilator drugs, nimodipine and other. And then usually they will end up in hyponatremia, SIADH, and all. You have to correct it, you have to give fluid challenge and those things. Okay, triple H therapy and those things are there. So but anyway, we have to refer to neurosurgeon at the earliest to do coiling or clipping of the aneurysm, or nowadays interventions are doing coiling of the aneurysm. So there are some cases are fit for coiling, some cases are fit for clipping and so this is this thing you can see in the left frontoparietal region. There is a extradural hemorrhage. This extradural hemorrhage is actually, it is a, how will you differentiate between extradural and the subdural hemorrhage? Show the subdural next slide.
Lucid interval, sir.
Okay, this is a subdural hemorrhage. So this is a concave outwards lesion. Okay, concave lesion, while extradural is a convex. So that's how that UDH and SDH are differentiated. Okay, UDH is convex in shape, concave in shape. Okay, so UDH is actually meningeal arteries getting ruptured. So it is a much actually serious, devastating issue. It can enhance, it can progress very fast. Patient, if not operated at time, can lose his life. Okay, so after trauma, if you are subdural, it's actually venous bridging vein rupture causing it. So it's a low pressure system. Veins, we know it's a low pressure system. It will produce very slowly only blood get accumulated. But in the EDH, it is an arterial rupture. Blood will collect very fast. Previous night, patient seems okay. Next day morning, patient can cone and die. So it has to be operated at the earliest. So EDH, we shouldn't take any time to refer to neurosurgeon. Okay, subdural we have got time to refer. Even small subdurals can actually blood gets actually this thing. It will only get brain out. If it's a very thin subdural, okay, no need to even do surgery. Blood gets automatically actually it will go off over time. Okay. If it's a large subdural with mass spectrometry, definitely it has to be referred. Okay. So common cause of subdural is trauma. Okay, EDH also it is trauma. So this is the hemorrhagic transformation of a cerebral infarct. This infarct, inside the infarct area, if a vessel gets opened up suddenly, it can rupture and produce the hemorrhagic transformation. So in a large MCA infarcts, large MCA tertiary infarcts, this thing, cerebellar infarcts are more prone for hemorrhagic transformation. It may, it usually hemorrhagic transformation occurs in the 24 hours or 48 hours. If we give heparin or even thrombolize the patient, large infarcts, they can end up with a severe or massive hemorrhagic transformation. So in a large MCA infarct, we don't thrombolize the patient because we will be doing more harm to the patient than good to him. Okay. Small hemorrhage and all is acceptable. Okay. If it is a severe hemorrhage, it can be life-threatening to the patient. Okay. Next slide. Metastatic tumors are many a times hemorrhagic. Okay. So, initially, if patient presenting with gradual progressive weakness, you do CT scan, you're seeing a hyperdensity. CT scan blood is described as a hyperdensity. Whiteness is itself hyperdensity, and darkness is described as hypodensity. In the MRI, brightness is described as hyperintensity, while darkness is described as hypointensity. That's a terminology difference between the CT and MRI. Okay. So here in this thing, we can see in the right frontoparietal region, there is a hyperdense and hypodense lesion with significant perilesional edema. That darkness is due to the perilesional edema. Okay. Okay. Next slide. Coagulopathy, patient having coagulation disorder, diathesis are prone to develop either single hemorrhagic lesion or multiple hemorrhagic lesion inside the brain. Here you can see in the right frontal region, high frontal region, there's a hyperdensity due to bleed, along with that just outside that we can see a significant darkness or that hyperdensity, that due to the perilesional edema out of these lesions. Okay. Okay. Next slide. Then and you can see the fluid level also. Here, arteriovenous malformation. Next slide. Next slide. Next slide. Okay. You can see there is a arteriovenous malformation which is previous one. Okay. That this hyperdensity, that whiteness is due to the blood and calcification to the blood. So it's so much hyperdense. The AV malformation is seen. If that ruptures, you can see blood also. Next slide. Here is a large aneurysm. In the second picture, that circle of Willis, there is a large aneurysm that is due to the basilar artery aneurysm. So otherwise called the topobasilar syndrome. If that aneurysm ruptures, definitely patient will die because basilar aneurysms are once they rupture, very unlikely patient will survive. Okay, with the large blood going inside the going to the brainstem cerebellar region. Okay, in the first slide we are seeing that hyperdensity is due to the basilar aneurysm. That central arrow is blue arrow is seen. It is seen in the CT scan. Next, that second one is the DSA, digital suppression angiography of the cerebral vessels, showing that aneurysm. Okay. Okay. In this amyloid angiopathy, we told there is a small bleeds even in the cortex diffusely involving frontal, temporal, parietal, occipital, everywhere. There are small bleeds. Okay. If we see this picture, and these sort of small dotted bleeds throughout the brain, very suspect more in favor of, especially if it will be an elderly patient with dementia if patient present dementia and seem to have this sort of picture in MRI, it is highly in favor of a cerebral amyloid angiopathy. Amyloidosis presenting in this manner. Okay. Next slide. Okay. Cavernoma. Wait, slowly. Okay, and then in the left frontal region, you're seeing a hyperdense, that bright thing is a cavernoma ruptured. Okay, cavernoma is a small vascular malformation, localized. It can rupture, but usually not devastating. Okay, it can, since being in the cortex, it can present with seizures and all. It may or may not be operated. Okay. Once presenting with seizure, it is there, patient may have to take lifelong anti-epileptic medication. So, usually not a serious condition. Okay. Next. Next slide. Srilakshmi. Okay. Dural AV fistula, again, some AV fistula, you can say that hyperdense lesion the right side due to carotid cavernous fistula here. And here, dural sinus thrombosis, cerebral venous thrombosis, it can be either dural or deep vein thrombosis. The same, they also usually present with the previous one. Srilakshmi. Previous one. Okay. Okay. This one. So it's a cerebral venous sinus throm. Okay. Usually, cerebral venous thrombosis are more hemorrhagic prone than arterial strokes. This is a venous stroke, but venous strokes are more hemorrhagic than arterial strokes. Most of the times they will present with some amount of blood inside that infarcted area, unlike arterial infarcts. Okay, and it is the cerebral venous thrombosis are more seizurogenic than arterial infarct. Next slide. Okay, brain capital leave. Next slide. Okay, spontaneous hemorrhage. Patient having a large pontine bilateral. Usually, if it is a pontine stroke, it will be unilateral stroke because vascular arteries are usually either left or right. They won't have bilateral pontine or bilateral basal ganglia. So it's usually unilateral, but bleeding, it doesn't follow that midline thing. So it can, usually it is bilateral. Okay, so it is the usually bleeding, intracerebral bleeding is due to the rupture of a deep penetrating the arteries. Okay, so and blood can flow in any manner. It doesn't suspect the midline thing. Okay, unlike arterial strokes where it is either left or right. Usually bilateral infarcts are very rare. Okay, but in bleeding thing, it is usually, especially in bones being the central structure, it is bilateral. So if it is a basal ganglia and all, it will be either left or right. So here, pontine bleed has actually gone into the fourth ventricle. That lower hyperdense thing is the blood inside the fourth ventricle, and it has produced hydrocephalus. That's why this temporal horn of lateral ventricle is dilated. The second picture, you can see that this thing, mustache-shaped thing. That is due to the dilatation of the temporal horn of lateral ventricle due to hydrocephalus. Since the blood has gone inside the fourth ventricle, it has obstructed thing, and the ventricles above it are getting dilated. So it will end up in a obstructive hydrocephalus later on. It has already started. So patient needs external ventricular drainage and all. Seeing this picture of the fontaine, patient unlikely will survive. Here we are seeing a left and left thalamic bleed. That blood is in the left thalamus. If it is a large thalamic, it can go inside the third ventricle, and again it can also lead to obstructive cytoplasm. Here is a small bleeding inside the left thalamus. Patient easily should survive. Next. Okay, this is a thalamic intracerebral hemorrhage which has gone inside. Blood has gone inside the intraventricular. Once it has gone intraventricular, what additional sign you expect? Patient will have neck stiffness. If it is only thalamic, there is no neck stiffness. Patient blood from the thalamus has gone inside the third ventricle, intraventricular extension. Patient's condition will be much more serious. Okay, many of them are prone to death. Then they may die. Many of them will die if not intervened properly at the earlier period. If it's a large large bleeding, definitely many times it is fatal. Okay, and clinically, no neck stiffness if it is purely thalamic. If it has gone, thalamic bleed has gone intraventricular extension. Additionally, in the clinical sign, we can see neck stiffness or the meningeal signs will be present. Okay. Okay. This is the left cerebellar hemisphere intracerebral hemorrhage. Okay. So cerebellar hemisphere hemorrhages are much serious conditions. Actually, cerebellar hemisphere and cortical lobar lobar bleeds are the one best to be operated. Okay, so they are near to the skull, so they are like outer surface. Cerebellar, if more than 4 centimeters in diameter, should be operated. Posterior craniotomy is the one they do. So they will remove the occipital bone, and the patient will and the patient brain will have more space to go outside. Otherwise, the hard skull is the one preventing them from expanding. Usually with bleed and infarcts in the cerebellum, with perlesional edema, they don't have enough space to accommodate it. Since they remove that part of the skull, is the posterior craniotomy is the procedure neurosurgeons do. Okay, and if it is more than 4 centimeters, it should be operated. Then we should have good results. Other deep fontaine bleeds never operable. Thalamic bleeds also hardly operable. This thing, basal ganglia also sometimes they try, but not much good results. But cerebellar large hemorrhages and large cortical lobar hemorrhages could have good results after surgery. Okay, next slide. So this cerebellar bleeds can have extension inside to the fourth ventricle. Okay, so once it has got intraventricular extension, these all bleeds are more fatal. So this is a lobar in the previous. Okay, lobar hemorrhage is very close to the outer part of the brain. So neurosurgeon can intervene and actually suck out that blood, so the patient will have good results. But next, B is a thalamic bleed, that is deep structure, not much good in patient won't benefit from surgery. Okay.
Okay, sir. Oh.
Over. There are a lot of connectivity issues and other things. So
Sorry for the inconvenience and the connectivity problems occurred in between.
okay. So I think many of the audience have left.
Yeah.
Yeah.
Okay.
Sorry for the
No.
technical issue.
Right. Okay. Thank you.
Thank you, sir.
Anybody having any doubts? It would have been better if, as I have asked you in the morning, you would have shared that thing so that I can also show it with the mouse. Then it will be more informative to others.
Okay, sir.
Okay.
Okay.
Okay. Thank you.
I think there is no more doubt.
Okay.
I would like to convey our gratitude towards Dr. Jibu Pecho for his expert discussion on CNS. And I would like to thank you, sir. I would like to appreciate the effort put by Dr. Sri Lakshmi for this discussion. I would like to convey gratitude towards all young family medicine residents who attended this session. Thank you.
Thank you.
Okay, sir.
Thank you.
Thank you, sir.
Okay.